I'm Katie-lynn Fisher-Nilson, and I'm going to be presenting on intraosseous access in the St. Joseph Mercy Oakland Hospital Emergency Department. The IO space is located in the bone marrow, and it can be used as a form of vascular access in healthcare for emergency situations. The IO space has small blood vessels called capillaries that provide access to the body's systemic circulation. IO access is achieved when a special catheter is inserted directly into the bone matrix. The American Heart Association recently updated their cardiopulmonary resuscitation and advanced care life support guidelines to incorporate the importance of IO access in emergency situations. According to the SJMO policy, only the emergency physician is allowed to perform IO access after 2 to 3 IV attempts have been unsuccessful. At SJMO, all of the emergency department patient care staff are required to attain the ACLS certification through the AHA. Limiting ED personnel who are able to perform IO access is creating a barrier to timely vascular access for patients. Delays in vascular access can increase morbidity and mortality rates. This is the SJMO policy, and in it includes that only the emergency physician trained in the procedure may insert IO access. The SJMO IO cannulation in the ED policy limits the staff members allowed to initiate IO access, which decreases utilization of this life-saving procedure. Other ED staff members hold the scope of practice necessary to perform IO access if they are trained properly. SJMO utilizes the Easy IO access device. All nursing and medical professionals who have undergone training may use the Easy IO access device to establish IO access once a physician order is obtained. Statistics reveal that IO access is an easy skill to learn for all ED patient care staff, not solely the physician. ED practitioner students who had never used an Easy IO access device before showed a 97.3% success rate on first attempts after training. In the study conducted by Diamond, ED nurses performed at a 90% IO access success rate, where physicians performed at a 93% IO access success rate, and paramedics performed at a 100% IO access success rate. IO access can be achieved more quickly and effectively than other access placements. In non-traumatic cardiac arrest cases, paramedics had a 91% first attempt success rate for IO access, as opposed to the 43% first attempt success rate seen in IV access. Complications arise in lower than 1% of IO insertions, making complications in IO access very uncommon. Another study showed early epinephrine used in 30 subjects with lethal heart rhythms revealed a decreased time to ROSC and better 24-hour survival than delayed IV epinephrine. In emergency situations, delays in vascular access produce a negative impact on the patient's chances for survival. This significant policy issue creates a delay to vascular access during crucial times in emergency care, and in turn increases risk of unfavorable patient outcomes. Vascular access is one of the most critical components to care in critically ill patients. Unstable patients in the SJMO ED who have unachievable peripheral IV access are at increased risk for morbidity and mortality. Despite the proven competency in IO access initiation from nurses and medics in literature, SJMO limits training and IO access initiation to only the ED physician. The lack of ED staff member involvement regarding IO placement delays vascular access during crucial emergent situations. Even though national organizations provide training strategies and algorithms for IO insertion, the SJMO policy lacks clear guidelines for staff members and appears incomplete. As a result, critical patients requiring IO access are threatened in their chances for survival. Anson conducted a systematic review with the purpose to determine the role of IO vascular access during CPR in hemodynamically unstable patients. Achieving an access site quickly in emergent situations is crucial for patient survival. In one trial, IO lines were placed 145.6 seconds faster than other access routes. A meta-analysis revealed there was only a 0.6% incidence of infection related to IO access sites. The Easy IO Access device requires minimal training and is effortless to use. 99 medical professionals were given a 5-minute presentation on the Easy IO Access device. The first attempt success rate with the Easy IO was 96.9%, with a median time of 6 seconds for insertion. Out of the total of 1,367 IO insertions in this systematic review, only 23 exertions exhibited complications. Complications included needle dislodgement and minor bleeding at the insertion site. Anson was beneficial towards this analysis because it concludes that IO cannulation is a safe alternative to IV access, can be achieved quickly, easily, and efficiently in emergency situations. A randomized controlled trial by Derricks compared physician and registered nurse performances utilizing two different FDA-approved IO access devices, the Easy IO and BIG. All participants in this study were randomly selected and individually trained by the same certified nurse educator. The training was conducted from the materials provided by the manufacturers. Educational training sessions lasted 1 hour, with opportunities for participants to ask questions and practice using the devices. Theoretical exams were conducted after material was presented in each group. Nurses averaged 88% and physicians averaged 84.5% on the first exam. Exams were given after 3 and 12 months, and both groups showed a significant decrease in scores over time. Derricks concludes that nurses were just as successful as physicians in IO device usage. This article was chosen for analysis because it exemplifies the successful ability in nurses compared to physicians when performing IO cannulation. It also reveals the importance of continuing education and skills training over time. Diamond conducted a 2-year descriptive analysis to assess the success rates of IO access by emergency nurses on adult and pediatric patients. Interventions took place at an academic tertiary care ED, and the ED clinical nurse educator collected the data. In the study, the healthcare providers performing IO insertions included the ED physicians, medics, and nurses. ED patient care providers completed an education model and a skill lab session provided by the nurse educator. The total time spent on education and training was approximately 60 minutes. An IO tracking form was made available to the staff who worked in the trauma bay. Completion of the tracking form was voluntary for all staff members. Adult patients have had an average of 2 peripheral IV access attempts before IO access attempt, compared to the 4 peripheral IV access attempts on pediatric patients. Physicians performed at a 40% first attempt success rate, where nurses performed at an 86% first attempt success rate on pediatric patients. For adult patients, physicians were successful for 93% of IO insertions, compared to 90% in nurses and 100% in medics. Diamond concluded IO placement tracking provides vital information for provider-specific IO insertion procedures. This article was chosen for the policy analysis because it provides high success rates for nurse and medic IO insertion procedures. Pedipus conducted a systematic review to promote IO cannulation in EDs and ICUs. IO access is largely underutilized. Physicians working in a UK ED reported minimal use of IO access, even though many were aware that it should be used. In Denmark, 0 out of 759 physicians reported using IO access in their practice due to lack of training and equipment. U.S. ED physicians reported that IO access became the technique of choice only after 4 other failed vascular access attempts. For adults, IO access is required for emergent situations as soon as peripheral IV access is deemed unattainable. After a 60-minute training video with hands-on practice, success rates on first insertion by physicians was 84% and increased to 97% after the second attempt. Pedipus is utilized for this policy analysis because it concludes IO access should be utilized more frequently in patients with trauma, shock, and cardiac arrest requiring emergency parenteral access. St. Joseph Mercy Oakland must change their policy to increase the number of healthcare providers able to perform IO cannulation to more than just physicians. The new policy should include nurses, medics, and physicians as the staff members able to initiate IO access. Including more healthcare providers allowed to perform this procedure will decrease the amount of time it takes to establish vascular access in critically ill patients. Life-saving medications will be administered quicker and decrease the patient's chances for morbidity and mortality. This policy revision is feasible and it should take priority over other revisions since it affects the patient's chances of survival.